presenter will be Dr. Ron Brookmeyer. He's the Dean of the UCLA Fielding School of Public Health, and he's going to do a presentation that's entitled Forecasting Preclinical and Clinical Alzheimer's Disease in Populations. And as with the other presentations, I've had an opportunity to preview this presentation. I think you'll find it very, very informative. Dr. Brookmeyer, you've got the floor.
Great, thank you very much. Let's see if I can share successfully my screen. Great. I'm assuming everyone can see the screen. So I first want to thank the organizers for this very informative workshop, and all the speakers. I've enjoyed all the talks in the session so far. So it's a pleasure to be here. What I'm going to be speaking about is forecasting preclinical disease as well as clinical disease in populations. And by preclinical, that is, we've made a lot of progress in understanding biomarkers for the earliest stages of Alzheimer's, and that plays an important part of the work I'm going to talk about today. So in the last decade, knowledge of biomarkers for Alzheimer's has grown enormously. We had the National Institute of Aging Alzheimer's Association working group defining preclinical stages of Alzheimer's before there are any symptoms. And then in 2018, the NIA Alzheimer's Association research framework on the biological definition of Alzheimer's was developed. These developments about biomarkers and about understanding preclinical disease lead to a number of, I think, critical questions. First, how many persons in the United States are in each of these different stages, whether they're preclinical stages of disease or clinical stages of disease? And what are the forecasts for the numbers of people in these different stages of disease? Second, how many of these people who may have preclinical disease would actually progress to AD dementia, clinical disease, during their lifetime? Are the biomarkers themselves predictive that someone would actually experience clinical Alzheimer's during their lifetime? And third, can we begin to get an assessment of what the impact of primary and secondary interventions would be on the forecast? By primary, I mean those that are that occur at the preclinical stage, that work very early in the pathophysiology of Alzheimer's, whereas a secondary intervention works more at the later stages of disease. So how do we begin to answer these questions? So the approach that we took, and the unifying theme, was that to develop a multi-state model for preclinical disease, and to use a multi-state model with the transition rates from going from one state to another. And what we did was we used published studies for these transition rates. And then together with US population census projections, we obtained forecasts. So that's the general idea. So let's begin with the multi-state model that we used. And this builds on the absolute central work of Jack and Sperling. And that multi-state model is shown here. That individuals begin in a normal state, and at some point they might begin to develop amyloidosis. And from amyloidosis, they then may also develop neurodegeneration. Now, these stages here are preclinical. The individual doesn't have any symptoms, but then they may develop mild cognitive impairment due to Alzheimer's. And at some point, they then might develop early clinical Alzheimer's. And as we all know, Alzheimer's has a lot of heterogeneity in the clinical symptoms. Sometimes persons only need adult supportive care, adult daycare, but ultimately it leads to late clinical disease at the level of intensity of, say, a nursing home care. At each of these stages, of course, persons are subject to death and may die from competing risks from other causes of death. Now, the red lines represent the main pathway to amyloid to Alzheimer's that's consistent with the amyloid hypothesis. But of course, there are possibilities that people may move and not follow the red transitions, but move through other possible transitions, developing, say, neurodegeneration before amyloidosis. So this was this multi-state model was the one that we used, and then tried to estimate the transition rates from one state to another. Now, we used the model was a Markov model where the transition rates were allowed to depend on a person's age, although not the duration of time they actually spent in the state, but rather their current age. To use it, we need to know the transition rates from one state to another. Now, if we know the transition rates from one state to another, then you can develop the transition matrix, which is the probability of transitioning from one state to the next state in a given year. And then by matrix multiplication of these transition matrices, you can calculate what's the probability of being in any particular state at any age. Well, if we have that, then we can multiply. We can get the prevalence rates by age and by gender. And then once we get the prevalence rates, multiply that by census population forecasts to get the number of people in the United States in each state of disease. So let's back up and say, okay, what about these transition rates? So the preclinical where do they come from? So let me give you an example. The preclinical transition rates, we relied a lot on a very, very important longitudinal study, the Mayo Clinic study of aging, where they've been following individuals and testing them in Rochester, Minnesota, for various biomarkers, including amyloid, neurodegeneration. And they've studied the dependence on age of these transition rates. So, for example, the rate of transition of going from amyloidosis, having amyloid in the brain, to having both amyloid and neurodegeneration in the brain. We also looked at studies that informed the transition from mild cognitive impairment to AD dementia, clinical AD dementia. And here we relied on an international cohort study that put together 13 cohorts throughout the US and Europe. In total, there were several thousand people involved in these two cohorts, which helped inform the transition rates that we used in the multi-state model. How are these preclinical disease states actually defined? What are the biomarkers that are actually being used? So for example, the state of amyloidosis, where you have excess amyloid in the brain, was based on amyloid PET screening, where one had an abnormally high standardized uptake ratio based on Pittsburgh compound B. Neurodegeneration was defined as an abnormally low FDG PET, abnormally low of the standardized uptake ratio, or based on an MRI, where there was a low Alzheimer's disease signature cortical thickness. The other transition rates from early to late stage Alzheimer's disease, that's going from when you need very modest care, supportive care for those who actually have clinical Alzheimer's disease, to late stage dementia where you need nursing home care. We relied on studies that looked at the time to development to nursing home care, needing nursing home care, and that suggested an average progression time of about 6 years, but that's just an average, and we used a distribution around that 6 years. And then mortality rates were used in each multi-state. Each state you could, of course, were at risk of death, and we used US death rates with certain adjustments available in the literature for those persons who had mild cognitive impairment or had Alzheimer's disease dementia, because they are at higher risk of death. And also these death rates depend upon age and gender. US death rates, baseline death rates, depend upon age and gender, and that's why our rates do depend upon numbers, and I'll show you, do depend upon gender. So now I'm going to show you some results. So what you're seeing here are the numbers of people in the United States in the states, in the multi-state model, for year 2017, and then a projection for year 2060. Now this chart is divided into two sections, the purple section and the blue section. The purple section are the clinical states: mild cognitive impairment due to Alzheimer's and actually clinical Alzheimer's disease. In the blue section, in the purple section, we're talking about clinical disease. There are over 6.08 million Americans are estimated to have been with clinical Alzheimer's in the year 2017. And that's broken up into two components: those that have mild cognitive impairment, which was 2.43 million, and 3.65 million who have clinical Alzheimer's. I believe this is the first national estimate of the number of individuals living with mild cognitive impairment in the United States. And we project the 6.0 million total of the purple, which is clinical disease, will more than double to about 15 million by the year 2060. Of the 3.65 million individuals who are living with clinical Alzheimer's, we're estimating about 1.5 million of those Americans are in late stage disease. That's about 42% of the clinical Alzheimer's that are in need of a level of intensity of level of care equivalent to that of a nursing home. Now, the top part of the curve shows you, the blue part shows you the preclinical states, those individuals without preclinical disease. And you can see about 22 million have amyloid in the brain, amyloidosis. Another 16 million have amyloidosis and neurodegeneration. The total of the blue section is that about 46.7 million Americans currently have in 2017 have preclinical Alzheimer's disease. This shows you the breakdown by single year of age of the estimates. So on the vertical axis is US prevalence in millions, and in the horizontal is single year of age. And you can see that, and it's for different states. So for example, let's look at the green curve, which is amyloidosis, excess amyloid in the brain. And you can see that more than half the persons living with amyloid right now in the preclinical state, just amyloid, they don't have symptoms, are actually under the age of 70 right now. And as you can see, as we move to more advanced states, the mode of the distribution is advancing. The clinical states, for example, let's look at these two red curves here, early Alzheimer's and late Alzheimer's. You can see the curves are shifted way to the right. And the big picture here is, when I look at this picture, I see most of the people are in the preclinical states. So most of the people, the green and the blue curves here are preclinical. This dotted line here is the mild cognitive impairment. So it's the dotted and the pink and the red, which are clinical. So most people are preclinical. And then as people age, the curves shift, and some make it to the clinical state of Alzheimer's disease. The majority of people currently in the United States with some AD pathophysiology are actually in the preclinical states. Only 11% down here are actually in a clinical state. So now we're actually in the, we actually now have an opportunity with this key idea of the multi-state model to evaluate the impact of different prevention interventions. Now, when we talk about a prevention intervention, it could be a prevention to slow the transition rate from one state to another. And it can be a primary prevention or what I'll call a secondary prevention. And I think the key idea is that we have to be careful when we talk about an intervention, such as a new medication or some kind of new drug, or other kind of intervention, whether it's a lifestyle intervention. At what state in the pathophysiology of Alzheimer's is that intervention actually happening? So what we looked at was a primary prevention, which I'll call disease modifying. So that was one scenario that could lower the transition rate to amyloidosis by 75%. And that would be a highly effective primary prevention, which is basically lowering this transition rate right over here. A secondary prevention that we looked at was a more moderately effective secondary prevention that lowered the transition rate to mild cognitive impairment by 50%. So people who are over here, for example, they've got something going on in the brain, amyloid and neurodegeneration. Can we reduce the onset of mild cognitive impairment, that transition rate, by 50%? And then a third scenario that we looked at for a secondary prevention was to lower was a much more modest, which was to lower the transition rate from mild cognitive impairment to AD dementia by 25%. So lowering this transition rate by 25%, that's pretty hard to do, because that's why we took a very modest one, because the person already has a lot going on in the brain and they also already have symptoms. So we're looking at just trying to slow that down a little bit. And then we looked at to see what the impact is of all this. And these are the results. So the vertical axis is US prevalence of Alzheimer's dementia. This is by calendar year. The black curve shows you, suppose we do nothing. And it just shows you the growth that we're going to expect to see in prevalence of Alzheimer's through the aging of the US population. But suppose we now looked at the the red curve, which was that first scenario, a highly effective primary prevention, and that lowers the risk of amyloidosis. And what's interesting here is that it doesn't do the best initially. The prevalence is actually as higher than some of these other scenarios, but in the long run, the red curve wins out with lower prevalence. So it has a somewhat higher prevalence actually in the first few years, but the reason why it ultimately wins out with lower prevalence is because the full benefit of primary prevention is not realized for many years because we're acting at the very early stages of preclinical disease. The green curve, which lowers the risk of MCI due to AD, as you can see, which was a moderate, had the greatest reduction in prevalence in the years, in the first few years, and did pretty well, although ultimately the red curve, scenario 1, wins out. The blue curve actually won out, had the lowest prevalence just for a couple of years. But then, of course, and the reason it had an immediate effect is because MCI is so proximate to Alzheimer's dementia, and that's what we were acting. And so it had an immediate effect because we were slowing the rate from mild cognitive impairment to dementia, but ultimately it didn't do anywhere nearly as well as either the red or the green curve. Now I want to come back to that question, that's startling number that I put on, which seemed really high. 46.7 million Americans right now are living with preclinical Alzheimer's as measured by biomarkers. Does that mean they're all going to get Alzheimer's disease? And so that's the question. And so the question here is how many of them will actually progress to Alzheimer's disease dementia, clinical disease during their lifetimes? And that brings us to the concept of the lifetime risk of Alzheimer's disease dementia, which is the probability of onset of AD dementia during one's lifespan. And because of the, and it's not clear because of the long preclinical period of this disease, some persons may not survive long enough to develop clinical disease during their lifetime. And it's going to depend upon this risk, lifetime risk is going to depend upon your age. It's going to depend upon your gender because death rates depend upon gender. And it's going to depend on the preclinical state that you're in when we're trying to calculate these lifetime risks. But we can actually use this multi-state model to answer these questions. So we used the multi-state Markov model I presented before with the transition rates, and we used that matrix multiplication. And we were able, using that to calculate lifetime risks, which is what's the lifetime risk that you actually at some point end up in the clinical Alzheimer's disease state, at least before you die from something else. Now, I want to say this calculation is not a Kaplan-Meier survival curve estimation. This is not what we're doing here. We are actually accounting for deaths that you can die from a competing cause and that you don't actually then ever make it into the Alzheimer's disease clinical state. The important point here is that lifetime risk that I'm going to calculate now depends upon your death rates that are acting. And here are the results of that. And what's new here and what's novel is that we are estimating lifetime risks by biomarker preclinical disease state. And so what we show here on the vertical axis is lifetime risk, and in the horizontal axis is your age. And the different curves here refer to your biomarker disease state. So, for example, I'm actually showing it to you here just for the males. We have separate curves for the females. So, for example, let's take a 75-year-old male, and it depends upon a 75-year-old male depends upon what disease state that individual is in. And when the individual is normal, which is down here, which is this blue curve, there are lifetime risk of, if you're 75 and have no biomarkers, your lifetime risk of Alzheimer's is 9%. Whereas if you have amyloidosis, which is this light blue curve, you're by a biomarker, no clinical disease, we're estimating your lifetime risk is 17%. If you have both amyloid and neurodegeneration in the brain, but no clinical symptoms, you're male, you're age 75, your risk is about 29%, your lifetime risk. What I want to point out is the blue curves here are the blue and green curves here are mostly the preclinical states, and your lifetime risk is of developing Alzheimer's is in most of these cases less than 40%. These red curves here are those with mild cognitive impairment, and they have much higher risk of progressing to clinical Alzheimer's during their lifetime. So back to the question, we then applied, we had estimated 46 million Americans have preclinical Alzheimer's based on biomarkers. How many of them are actually going to progress to Alzheimer's disease dementia during their lifetime? So we used those lifetime risks that I just showed you and applied them to the 46 million, breaking them down by which biomarker state they were in and what their age was, and multiplied by the lifetime risks. And actually only about 12.6 million Americans of the 46 million currently living with biomarker-defined preclinical disease would actually progress to Alzheimer's disease. So much less. Can we corroborate some of this data? Yes. These were the first estimates of lifetime risks by biomarker states, but there have been some studies such as the Framingham study and the Canadian study of health and aging, which reported lifetime risks of Alzheimer's disease, not by biomarker state. And so what we did was took our estimates and averaged out over biomarker states and got estimates that were actually within the range. They were higher than the Framingham, but lower than the Canadian study of health and aging. And we compared it to a number of other international studies. And what we found is that some were higher and some were lower, and ours were in the middle of the range. We also did another corroboration just about like how consistent is this multi-state model with all the other studies that have been done on Alzheimer's disease incidence. There are a lot of studies that have studied the incidence of Alzheimer's disease by age, but they haven't looked at biomarkers. And so what we did was just look at our multi-state model that accounted for biomarkers and then said, okay, what does it predict the incidence rate is of Alzheimer's by age without regard to biomarkers? So we were able to do that. And the first thing we did was look at all the studies in worldwide studies. We did a systematic review that got estimated Alzheimer's disease incidence by age, and each dot here represents a different study throughout the world. And we looked at the incidence per year. This is on a log scale, and of course we see exponential growth with a doubling time of about 5 years, and came up with this equation. Then we looked at what our multi-state model predicted. And here again is the incidence per year of clinical Alzheimer's versus age. The red is that systematic review that I showed you, that line, which shows exponential growth. And the black curve is what our multi-state model, which used biomarkers. I want to say that the key part here is that the data sets were completely different. Red curve was a systematic review of all studies of Alzheimer's that have been published on longitudinal studies that gave incidence. And the black curve is the one that was based on the multi-state model with the specific transition rates of moving from one state to another. Okay, to summarize, lifetime risks that I presented here help interpret the clinical significance of biomarker screening tests. Just because you're positive on a biomarker doesn't mean you're going to get Alzheimer's during your lifetime. Most persons with preclinical Alzheimer's will not develop AD dementia during their lifespan, but some do. Some are at high risk of progressing to disease. It depends upon your age and what state you're actually in. The approach that we've taken can help evaluate the impact of disease-modifying interventions and the impact of secondary and primary preventions. I want to emphasize, and key here is that ethnically, it's important to get transition rates for more ethnically diverse populations than what we used here. And an important extension, I think, will be to extending it to the ATN framework that accounts for tau. I'd like to acknowledge my collaborators, Anad Abdallah at UCLA, Maria Carrata at University of California in Irvine, and Claudia Kawas at UCI, also at Irvine. And here are some references on some of this work. And thank you very much. It's a pleasure to be here.
Okay. That was a very interesting and informative presentation. There are several questions, but I'm thinking in the interest of time, our commitment was that all the questions, if they weren't answered during the live session, would be provided to the presenters and could be answered in I think relatively quickly as follow-up questions. We know who the questioners are, and so if we have the opportunity in the general questioning, we'll come back. I had one or two questions that I might want to pose, but I think in the interest of time, we'll defer that.